Thank you very much. So we do know that in critical limb ischemia, we have a transmission failure and distribution failure, as Art had said. The distribution failure is due to small artery disease and leads to problems like no outflow or the desert foot. And in many of these cases, you see on angiogram, typically the patients are diabetic with poor control and dialysis dependent. Now, SAD patients or patients with small artery disease are ineligible for current conventional techniques, and we estimate that this group of patients is probably about 10% of your practice, depending on where you practice. And that leads to not just gangrene, but also leads to the debilitating problem of chronic wounds. Big artery disease versus small artery disease, a typical angiogram looks like this. You don't have an artery on the distality that you can bypass or land a wire and pass a balloon. Small artery disease is, as you can see in the upper right, has been scored and has been independently associated with a poor outcome. It's no SAD, moderate SAD, and severe SAD, but it's fairly subjective. And Roberto Ferraresi, who's done a lot of work in this, has had it correlated with a calcium score of the foot, if you like to call it, and it's called a MAC score. So if you do a plain single shot or conventional x-rays, you'll be able to estimate the amount of small artery disease just by looking at the calcium. And it's been seen that in patients with small artery disease, the wound healing can be quite dismal, and up to only 30% of patients with moderate to severe small MAC or middle artery calcification or small artery disease actually completely heal your wounds. As I mentioned, this is some of our Japanese series with no pedal arch angioplasty or PAA type 3, typical angiogram on the left. And if you look at this patient's complete wound healing rate, not improving, but complete epithelialization of the wound was only 30% at 6 months as well as 12 months, leading to a very poor clinical result and no resolution of critical limb ischemia. In the series from Roberto, and they do have a pretty good center with wound care, podiatrists, and so on and so forth. And in moderate to severe small artery disease or middle artery calcification, wound healing, complete wound healing was only less than 30%. So venous arterialization was a potential way that we could solve this problem. How does it work? We basically join the artery to the vein and send the arterialized blood through several circuits. And this was recently FDA approved and it's been commercial in the US for a while. Typical angiograms you see on the left, and after a period of time, after a 6 to 8 week maturation, the angiogram actually changes and matures quite differently, as you can see from left to right. An example like that, you can see severe amount of calcium. I couldn't get the AT open, pretty much no outflow to the foot. And severe calcium, as you can see, and after a procedure these days, we would get this kind of a typical result, and this is the kind of speed that you get, and you get a nice whoosh, and AP angiogram, you can actually see forward flow in a patient with both ischemia and osteomyelitis. Some of the surgical and percutaneous data, this is a meta-analysis done some time ago. Let's pay attention to the wound healing rates. The 12-month wound healing rates were 64.5% in this bunch of patients who underwent surgical and percutaneous venous arterialization. More recently, a meta-analysis of the percutaneous version. I believe this was without the promised results, but essentially the wound healing rate at 12 months was 69.5%, certainly with a higher re-intervention to keep these circuits going. This is the PROMISE-2 study for the lymph flow device that was published in New England Journal of Medicine. And I've tabled all these results of on-label lymph flow devices, including the CLARITY registry, which is a registry of patients with no option CLI treated conservatively. As you can see, have attention to the last column of complete wound healing. Of course, as those may know that the PROMISE 1, 2, and UK studies were all core lab adjudicated, but one can see is that a pretty decent wound healing rate at 12 months of 60 to 70%, especially if you have a very good wound service, like in the UK and in the national healthcare system, where they do a very good multidisciplinary care. Recently, it's also been shown to be possible from a societal consensus point of view. So how do I select these cases? Well, if certainly we don't want to select the no hope leg, which is severe extent of gangrene, severe heel wounds. In these patients, these legs have to go into the box. You can't do anything for this if you can't get a functional foot. So this would be the typical cases where the ischemia is limited, infection is limited to the toes, and even if you have osteo, you can remove the toe and still get wound healing if you do the procedure. These are not advisable for venous arterialization. These legs are too far gone and due to soft tissue loss, you can't get a salvageable leg from this. Heel wounds are not advisable. Small heel wounds maybe, but large heel wounds are definitely not advisable. Screening anatomy, if you have a typical patient like that, we like the posterior circulation, so this is the anterior occluded posterior, you're just adding blood to the equation. You do the procedure, not steal blood away from the existing collateral, which is a peroneal artery in this case. Another case of a anomalous peroneal artery. And what you want to do is you want to bring the blood from the peroneal artery into the vein and then add blood to the equation rather than take away blood. Another case with the AT going with the trunk occlusion. This is a classic case where you let add blood to the equation, not by stealing blood from the existing anterior arterial artery, and then do the procedure and get blood to the foot. There are a couple of phases. There's phase 1, which is the early phase, which is a 0 to 2 week mark. And then there's a second phase, which is a maturation phase. And the aim of the first phase is to get the circuit running and not steal. So there are a couple of factors that determine the amount of blood that goes into the venous circuit. It's the arterial inflow pressure, the arterial outflow resistance, the diameter of the shunt, and the location of the shunt relative to the largest collateral, which is the peroneal artery in this case. So if you have a patient with severely occluded, who's only surviving on collaterals, if you had an excessive amount of shunt with a very generous crossing stent, what would happen is the blood would always preferentially flow into the venous circuit, and this could potentially steal blood from existing collaterals. In these kind of cases, you want to cross a little bit more distally. So how does it fit into my practice? 1 or 2 case examples. This is a patient with moderate to severe MAC score infection, first toe amputation by an orthopedic colleague, not getting better, cellulitis. Now this patient is heading for a disaster. Plain X-ray like this, you get a sinking feeling in the heart that you're going to be going home late. So in a patient like that, I try to get the DP open. I can't. It's based on the tarsal. I add blood flow into the posterior circulation, pump the patient with antibiotics because of the cellulitis, take off the medial marginal vein by coiling it to try and focalize the blood and push it further. So in this case, you can see in a pre-procedural TCPO2 of 20. After the procedure, it starts to rise. You embolize it, and you get that perfusion all the way up to 79 millimeters mercury of TCPO2. And finally, for the wound, you can get a good granulation. By 2 months, you start to see the wound starting to turn. No skin grafts, and you're able to get wound healing. But if you slept on the skin graft at 3 months, that would have healed it at 3.5 months. Another patient, heel gangrene, not healing for 1 month, sent the patient for hyperbaric oxygen, not responsive to hyperbaric oxygen, low TCPO2 around the wound, not so severe, 46 is just sitting on the line, not classically no option. If you wanted to bring the blood to the heel, you would have to jeopardize the whole plantar arch, balloon that to try to get the blood around, but because of the ballooning of the plantar arch, you would put all the other toes at risk. This patient, we did venous arterialization, we added the blood returned, and I think it actually perfuses the heel through the short saphenous system. And you can see a precipitous rise in TCPO2, and this patient had healed primarily without a skin graft, and you can see on infrared thermography, the foot is a lot warmer. Another patient, 56-year-old, young patient with infected heel gangrene, failed posterior artery recanalization. The anterior is looking pretty good. The blood is not exactly heading towards the heel that well, and we added the blood by doing venous arterialization. You can see after about 2 or 3 weeks, you can see the wound start to turn, slap on the wound vac. This vac, typically we run at the intermittent vac at low pressure. And then we put on the skin graft, and that heals completely in 3.5 months with a very different TCPO2 before and after the procedure. What do we do these days? What is the future? Maybe this could be a solution. It's a distal DVA. We don't know. We still have to do more of these cases and document a rise in TCPO2. This would be the classic case, 73-year-old, dialysis, good heart, refer another hospital. If you look at this, it's pure BTK disease. This is a typical AT stenosis that's pretty focal over here. It's treated with a drug-eluting stent, and then we add by ballooning the posterior tibial artery, and we, instead of putting all that money into all these expensive stents, we actually do a distal DVA, and we're able to jack the pressure all the way up and get primary wound healing by 5 months. It's a future, the DVA for both bad and sad disease. If the blood-coated balloons don't work in tibial, if you can't afford, maybe you could, if you can't afford miles of absorbable stent or coronary drug-eluting stent, maybe the DVA could treat a patient who has both bad and sad disease. Can this be a viable option of long segment bad disease combination with sad disease? I don't know. But anyway, in conclusion, DVA is a new degree of freedom to heal wounds. Dilemma is not whether it works, but who can do it. The option of distal plantar arch angioplasty that Art has shown you, or you want to do a DVA, I think the verdict is still there, out there. Thank you very much.